everyone. Today I'm going to interview the Vice President of Fascia Research Society, Dr. Tina Wang, about a super interesting topic. So good morning, Tina. We said it's 6 o'clock in the morning in California. And thank you very much for being here and to say yes to this interview about this topic that I said it's very interesting in my opinion. But I want to introduce you. Okay, so I'm going to read because your CV is fantastic and I want to be precise. So, two words about you. You are a physical medicine and rehabilitation medical doctor, assistant professor of medicine at Loma Linda School of Medicine, University of California, Riverside, and Southern California University of Health and Health Sciences. And of course, you are a fascia researcher. So good morning, Tina.
Good morning. Thank you for having me here. I'm very excited.
Tina, the topic of this interview is fascia and its alteration in hypermobile people. So my first question for you, can you define what is hypermobility and is such as a characteristic of a person or we can consider it a disease? And hypermobility and the Ehlers-Danlos syndrome are the same thing?
Yeah, what a great question. This is a common question I get and one that I educate all patients about as well. Not all hypermobility is pathologic. Many people in the population, about a third to a quarter, those are the estimates, have hypermobility. That means you're super bendy. So maybe your joints go past what is for the rest of the population considered normal. Maybe you're extremely flexible. And the majority of these people have absolutely no problems. They go through life, they're fine. They don't have pain, they don't have any related syndromes or systemic issues related to it. But a small percentage of these people, about 2%, have problems. And these are related to the hypermobility. So they're not caused, they're correlated. So what does this look like? It looks like the unstable joint. So maybe the elbow or the wrist, the patella, the knee, they dislocate or are unstable. And the joint breaks down, the ligaments become injured, there's pain, there's a lot of balance issues. So in this group of people, we call that hypermobility spectrum disorder. And about 1/5 of these people then meet a stricter criteria for Ehlers-Danlos syndrome. And that's when we start to see systemic signs of connective tissue fragility. And what are those? It might be the pelvic organ prolapse. It might be hernias. They're piezogenic papules where the fat herniates through the fascial layers. So we look for signs like this to see if a person meets that stricter diagnostic criteria for Ehlers-Danlos syndrome. So if you're walking on the street and you see a super hypermobile person, doesn't mean that they have Ehlers-Danlos. A lot of people are perfectly fine even though they are hypermobile.
And why fascia is so important in hypermobile disorders, and why fascia result altered in these people?
Yeah, I wrote a consensus, or not a consensus, summarization of fascia's role in hypermobility. I published a paper recently summarizing all of this. I think that the disorder originates in the fascial tissue, the pathological origin of this, or the pathologic interface, because in the fascial tissue, we have immune cells and fibroblasts, which are the cells that produce the connective tissue, the extracellular matrix, the collagen. They interface with the immune system in these fascial layers. And they also interface with the neurologic system, the autonomic nervous system in this tissue, so that you get this interplay between the nervous system, the vascular system through the nervous system, and the immune system, and the fibroblasts for the connective tissue. And when these different systems interfaced here, we start to see the manifestation through the whole body of these conditions, so that it's not just being bendy. Now there's allergy problems. Now there's problems controlling blood pressure. Now there are problems with proprioception, knowing where you are in space. And there's problems with your gut, because all of these systems also coalesce there in the connective tissue.
So it's not something that regards just the joint, but at the end of the story, that regards all the body.
Yes.
Because of the connective tissues, because it is everywhere in the body.
Yeah, and the connective tissue really is the most compelling story for the point of origin.
This is super interesting. So can you tell me something more about that specific big research that you made, that publication that you made that covered all this alteration of the fascia in these people, and something like how many people were involved in this research, and also did you consider a specific region of the body when you made this research, or the whole body? How did it work?
Yeah, what a wonderful question. Of course, I would love to scan the whole body, but that is not feasible. So in fascia research, the Stecco lab is the powerhouse of normals. They will ultrasound all these different areas to try to produce normal values. And Antonio Stecco, one of his landmark studies was of the SEM. So he helped guide me in choosing some of the areas that I looked at in my study. I wanted a weight-bearing area. I wanted a non-weight bearing area up here in the SCM. And we took a look at the iliacus fascia and the trunk, and we looked at the densification. Is it much thicker? And is it more of that extracellular matrix, the glycosaminoglycan? Is that what is thicker? And what is going on in there? So Antonio's study showed that in people with head and neck pain, there's a densification process, a much thicker, deep fascial layer. And what I found in the Ehlers-Danlos population was that this was even thicker. It was amplified, particularly up in the SCM where it was non-weight bearing. So it was extremely interesting. And using elastography, what I found was, compared to non-hypermobile people with pain, non-hypermobile people with pain had a greater differential in stiffness. So that underlying muscle was pretty stiff, and that overlying thickening deep fascia was soft. So when we go and feel our clients, that's the trigger points, the stiff muscle that we are feeling. In the Ehlers-Danlos population, this didn't happen. It was thicker. The deep fascia was thicker, more than those without hypermobility with pain. But the underlying muscle was not stiffer. It was all the same texture and stiffness. So when we go and feel the tissue in our Ehlers-Danlos patients, it just feels mushy all the way through, a single texture. And we're not always capturing that stiff muscle underneath. It doesn't mean that it's not stiff. It just means that the differential in the tissue texture is not there. And it feels very mushy under our hands when we go to diagnose or palpate. The I'll stop here because there's more research, but
No,
I'll
but I'm thinking when you're speaking, I'm thinking to hypermobile people I work with, clients, I mean. And yes, you said that they are moshi. I was thinking, we say in Italian that they are like pizza, moshi.
Joey.
And yes, it's true. Their tissue, I mean, their arms, their legs are always like that. It's true. I was thinking to my clients, and I was thinking to something that you said before about the densification of the fascia. I was thinking to the study that Fabiana made about the thoracolumbar fascia. And every time there is an alteration in any kind of disorder, alteration of the fascia, of course, there is always a stiffness, a densification of the fascia. This is interesting, right?
Yeah.
I
And
interrupt.
yeah. And so there's even more. There's a condition called lipedema that
Yeah.
is gaining in terms of people's understanding or acknowledgement of its existence. And so it can be co-occurring with EDS and hypermobility, HSD. And I did a study with Claire Francomano, started by Wendy Wagner, who brought us all together. She's a physio in America who brought this team together. And we looked at lipedema in Ehlers-Danlos patients, and we found a correlation between the thickness of that lipid layer that often occurs with lipedema. It's diagnosed as being thicker because it's inflammation in that lipid layer. But we also found a correlation with deep fascial thickness, as well as the presence of immune dysfunction. So these things were all interrelated. And then we found correlation between immune dysfunction and dysautonomia, the dysregulation of that nervous system, which can manifest as irregular heartbeat and poor blood pressure control. So in this follow-up study, we were able to show that this is a system-wide issue.
Yeah, absolutely. In the next Congress, there is a workshop regarding the lipedema, right?
Uh, I believe so. We have Dr. Eicher coming, and she did a similar study looking at lipedema, and she will be presenting a poster there. So everybody go and talk to her. I'm really excited to
Mhm.
meet her in person and talk to her about her work. And I don't want to steal her thunder. So go over and see her results, which are supportive and
Yeah,
similar.
absolutely. Okay, Tina, this is my last question. So, is there a way to reverse, if you can say, to reverse or to fix the effects of hypermobility? Or if you are born like that, that's it. You can do anything. I mean, for example, in the disciplines that I teach in Soma training in Eldoa, there are a way that we use to fix, to help people with these characteristics. So we work improving their strength, improving their awareness of the body, and of course, you said before, their proprioception. But can we do something? Can we reverse? Or, I mean, you were born like that. That's it.
No, yes and no. Yes and no.
Yes.
So the some of those follow-up studies I did showed that with this densification, this thickening, there is impaired gliding, interfascial gliding.
Mhm.
So now you can imagine if there's impaired interfascial gliding, then when you contract a muscle, instead of proper force dispersion through your aponeuroses into a fascial chain movement, now we get too much pressure, like a MDF particle board, right? And it's now super strong with all of these particle boards stuck together. And that's when you yank at a joint and it dislocates or subluxes or has ligamentous capsular damage. So you can imagine if there isn't proper glide, then we can use manual therapy, movement therapy to start to get the tissue to glide. And then if we can start to get proper force dispersion, then the afferents, the sensory pathways coming back, can start to function a little bit better in terms of your proprioception, as well as the output for understanding where your joint position is and how to control that joint position so that your muscles don't have to work so hard, your body doesn't have to work so hard for basic human movement. So absolutely, both manual and movement therapy are crucial to the management of this condition. There's a great study done in children that shows that ballet intervention is protective. It's protective. And so it doesn't take away the deficits that are there. So a lot of these studies, I am a performing arts medicine specialist, and a lot of these studies happened in the 1980s, 1990s in ballet dancers and musicians. And these studies show that proprioception is impaired and strength is impaired, just for the reasons that I talked about. And when there is training, it's protective, so that even though there is manifestation of the pathologic process, it can be curbed, possibly reversed, but not in all people, just in one manner. And many of our patients also need medication management as well for the inflammatory and autonomic involvement as well. So that manual therapy, movement therapy, and a good medical team can be very supportive of these patients, and they can start to live a functional life, not normal life, but a functional and well-balanced and hopefully joyful life.
I'm happy because at the end of the story, it's what we are doing. So I'm happy that you are saying this because teamwork and working to improve the quality of the tissue, to improve the sliding of the tissue, and a lot of work on proprioception. So we say the inventor of the methodology that I teach, Dr. Givoye, used to say that we teach to the intelligence of the body. This is interesting. Okay, Tina, we finish. I waited until the end of this interview to tell to our audience that, I mean, you guys, the people that are listen to this interview, can meet Dr. Tina Wang in few days, in few weeks, in few days in New Orleans at the Fascia Research Congress. I'll be there. I can't wait. You will be super busy. And it will be a success for sure. I mean, how many people joined at the moment? Like 500?
Yes, we're at 500. We
Oh my
will
goodness.
keep trying to make room. We're busting at the seams, and we're so excited to be,
All over the world.
yes, all over the world. We are so grateful, so excited to be able to interact with all of these wonderful people who are interested in fascia science and fascia research.
Uh, to end with quoting the president, Fabiana, she said once she said to me, "This is just the beginning. There is many things that we can do, many things that we can study about fascia, right? Many things that we can do."
Yes, and that is the mission of FRS and the Congress, is for us to start to interact together, to talk, to start to collaborate so that we can take what you see in the movement, in the manual therapy, and use the science to show that what we're doing with our hands and with our movement are making a real effect in the lives of our patients.
Absolutely. There is something that you want to add, Tina?
I just want to thank you so much for
Oh, no,
the
you.
amazing work you do and for all the lives you change and influence with your podcast, with your clinical work. So grateful for you. It's people on the front lines like you who are making a real impact in the lives of our clients and our patients. Thank you so much for what you
Thank you,
do
Tina.
and coming to the Congress and presenting and being a part of this next generation making a difference in the world.
Okay, Tina, see you there. I said in few weeks, in few days, and that's it. I will post this interview in my website, and probably you will do too, and in my YouTube channel and on Instagram. Okay, thank you very much. Stay there. Ciao.
Bye-bye.